Hello and welcome to today's episode of Post-Acute COVID-19 Exercise Rehabilitation PACER Project session. Today's session will be covering home health considerations, and this is current as of May 2020. First, we'd like to thank the APTA Geriatrics Academy, Home Health Section, and especially thank Cardiovascular Pulmonary Section for sponsoring today's session. This course is intended for educational purposes and does not replace mentorship or consultation with more experienced colleagues. This content is current at the time of dissemination. However, realize that evidence and science on COVID-19 is rapidly evolving and information is subject to change. My name is Dr. Kenneth Miller. I am currently an assistant professor at the University of North Texas Health Science Center in the Department of Physical Therapy. I am a board-certified geriatric clinical specialist. My specialty practice area is home health as well as outpatient practice. I am faculty for APTA Geriatrics Certified Expert for Aging Adults course, and my disclosures are working for that course, along with working with MedBridge and great seminars with other educational content available for physical therapists and physical therapist assistants practitioners. Now I'd like to introduce my co-host for today's session, Dr. Melissa Bednarek.
Hello, thank you, Ken. And again, thank you to the sponsoring sections of this PACER project session. My name is Melissa Bednarek. I'm an associate professor at Chatham University in Pittsburgh, Pennsylvania. I'm also a board certified clinical specialist in cardiovascular and pulmonary physical therapy with clinical experience in the acute care realm, as well as outpatient pulmonary rehab, and most recently in home health. I'm also faculty in the Advanced Competency in Home Health program through the Home Health section. So my disclosures, again, also include faculty in that program, as well as some educational sessions for MedBridge.
So here are the objectives for today's course. By the end of the course, the participant will be able to define self-monitoring, quarantine, and self-isolation, differentiate between asynchronous and synchronous telehealth type visits, list the 4 types of COVID-19 presentations, and describe indications for prone positioning with acute respiratory distress syndrome. Now, before we get into specifics of decision-making, there are really 2 buckets I'd like to talk about in the next few minutes. And the first bucket is called the rules and insurance bucket. And the second bucket is called the health and clinical bucket. I'm going to start with the rules and insurance bucket. And the reason we need to discuss both is this will help us with accurate decision-making and appropriate decisioning for our patients and for ourselves. And given that we're living in the COVID-19 era, this is a communicable disease. So we need to look at both the rules, what's covered, and then the clinical aspect of how do we contain this virus and how do we try to minimize the issues this virus is causing. So first, looking at the rules and insurance, really there's 3 different areas that the way our law comes down to becoming part of our practice. First is Congress and the president will sign a law. They'll create a bill, pass it, and it'll become law. And so that law will then be filtered down to regulations. And the regulations are interpretations of the law based on information that the Department of Health and Human Services, Centers for Medicare and Medicaid Services, they'll take the laws and then they'll create regulations. And then those regulations will be disseminated to all of the different providers, the different organizations. And then those agencies and organizations will create policies. They also will follow accreditation standards, which are based on the regulations, which are based on the laws. So a very easy way to think about it is we have the Affordable Care Act or we have the HIPAA Act. Those are laws that were put in place. And then based on the HIPAA Act, then regulations were created to further define what the law is saying. And then we create policies based on the regulations to make sure that we're truly following the intent and the letter of the law that goes back to the HIPAA or ACA or any of the other federal laws. We also have state laws, and for the purpose of this session, we will not be talking about state practice acts. So these are things that you need to go back and look at your own individual practice act for your license and see what you are allowed to do, what's not allowed to be done, and what your state may be silent on. So we have our federal law, we have our state law, we have regs, and we have agency policy. These different levels of information are also influenced by World Health Organization. World Health Organization is not a legal body in the United States. However, they do have information that is being incorporated into our policies and into our regulations, such as infection control, hand hygiene. So World Health Organization is a major player in what becomes law, but they are not the lawmaking body. Now I want to move on to clinical health factors, and we'll talk about this a little bit more in detail than I talked about the rules and the insurance bucket. But most importantly, with the clinical and health factors bucket, really has to do with patient safety. All of us became clinicians, and we all have been drilled into our heads patient safety. And many of us are very safe with our patients with regards to their physical safety, risk of falling. But we need to look and open our lenses a little bit wider and look at patient safety from a communicable disease standpoint. And so I'll talk about that in just a moment. But in looking at clinical factors, we need to look at the patient safety. We need to look at the patient's health, okay? It's not only fall risk, but also health. Patient has comorbid conditions. We need to be aware of these things. A patient may be a part of a vulnerable population. An older adult is a more vulnerable population. A younger adult with many comorbid conditions is a vulnerable population. And we're now learning that children are also have a vulnerable population for COVID-19. So patient health, also family caregiver health, working in the home environment. Many of you are very familiar with family members present at the visit, very familiar with family members leaving the house in the pre-COVID era. Oh, you're here now, what time do I need to be back? And taking the opportunity to leave. So family health and caregiver health, when do they leave, and what's the risk of that person either carrying COVID-19 or getting COVID-19 from either your visit or from the patient. And then lastly, and doesn't mean to be least important, it's just as important, is clinician health. Being able as a clinician to be safe with maintaining your health to avoid yourself from contacting and contracting COVID-19. So let's talk about the different levels of quarantining and different definitions we have here. So first one is very common, and you probably have heard a number of times, social distancing. And the definition of social distancing is staying at least 6 feet away or 2 meters from other people and not to gather in groups. So when the COVID-19 virus first started its way across the United States, many different municipalities put in regulations and put in policies of not having gatherings more than 100 people. And then it became gatherings more than 50 people. So according to social distance, we should not be gathering in groups in any which way. Stay out of crowded places, avoid mass gatherings. Cover your mouth and nose with a cloth face cover when around others, including when you have to go out in public, for example, to the grocery store. Now, we know that the cloth face cover is not going to protect you yourself from the virus because of the pores in the cloth. The idea of the cloth face cover is so that you, if you are contagious, do not spread the virus through coughing and through secretions. Next definition is self-monitoring. Be alert for symptoms, watch for fever, cough, shortness of breath, take your temperature if symptoms develop. So we all should be mindful of monitoring ourselves for these symptoms. And the biggest challenge with knowing these symptoms is fever, cough, and shortness of breath could happen with other conditions as well. So just having these symptoms doesn't mean that you're positive for COVID-19. It just means that we need to be monitoring and then possibly testing for that illness. Quarantine, purpose of quarantine is to keep someone who might have been exposed to COVID-19 away from others. So someone in self-quarantine stays separated from others and they limit movement outside of their home or current place. And I'm going to expand that definition for us within the home is to keep that person inside a specific part of their home. They shouldn't be flowing throughout the whole house with other people that may not have been exposed at that point, because the more that the person that is potentially containing the virus moving through the house, the more risk for other people living in the home. So for us, self-quarantine is not just staying in the home, it's trying to maintain a specific space inside the home. And then isolation, this is the most significant of the four definitions here. And this is used to separate sick people from healthy people. So this is for people that are known to have the disease and they they may be symptomatic or not, but they have tested positive for the illness. People who are in isolation should stay home. And then in the home, they should separate themselves from other family members and other visitors to the home. And they should stay in a specific sick bedroom or space and try to use a different bathroom if that's possible. As far as clinicians working in the home, knowing that COVID-19 is in the community, decisions need to be made within the organizations regarding assignment teams. You know, are you assigned to an assignment team that will treat COVID-19 or a non-COVID-19 team? So those are things that you need to know as a clinician is which population will you be working with? And if you are just dedicated to working with non-COVID-19 patients, be aware that people that are non-COVID become, COVID, so that it's not like you're out of the woods with monitoring and with evaluating patients for these symptoms. But if you're on a COVID-19 team, you should have the proper PPE. You should definitely have the N95 masks because the risk of catching COVID-19 is greater when you're working with people that have active disease. All staff should be self-monitoring regardless of which team you may be assigned to. And you could be assigned to a mixed team as well. You may not have the staffing to have COVID versus non-COVID-19. You may have a mixed team where everyone's treating everyone. But regardless, all of us need to be self-monitoring using the CDC guidelines and then using telephonic check-in to our agencies and to our supervisors to let them know whether we are able to work or not, and then decisioning whether we need to be quarantining ourselves or, for 14 days, depending on if we are symptomatic or not. And then a positive screen follow-up with the physician, and that's where the decision will be made, what should we be doing. And then testing is when appropriate and where available. As far as scheduling, looking at this from a clinician point of view, it's important to look at how often are we seeing our patients, and are we seeing our patients twice a week, 3 times a week? What does the patient actually need? And we need to now weigh the amount of visits we make versus the risk of having more and more interactions with the patient. So we may need to reduce our frequency to the minimum safe number of visits for our patients and really put more on the patient to do with their family members with regards to the interventions we're providing. But most importantly is adding in telephonic follow-up phone calls to follow up with the patient, possibly adding in telehealth visits, and I'll talk about that a little bit later. But these are different things that we could help with our patients in between our physical visits to help with following that care plan and helping that patient progress towards achieving their goals. Some have recommended co-visits with the nurse or other disciplines to make sure that when we are donning and doffing the equipment, we have a second set of eyes making sure that it's appropriate, making sure that we're not exposing any part of our body with the gown not being properly placed, and making sure that we follow the correct order with donning and doffing our gloves and our mask and whatnot. We should be seeing our high-risk patients first because of immune status. And now I'm talking about non-COVID patients. So our patients that are most vulnerable, that have COPD, heart failure, or other comorbid conditions, the people that are most at risk to be rehospitalized, those patients should be seen before we see anybody that has a communicable disease, because we don't want to carry the disease into their home. Patients with communicable diseases, in particular COVID-19, should be seen last. So that way, when we're finished with that last visit, we can then follow disinfection protocol for ourselves, take off our PPE, go home, shower, and remove our work clothing, whether it's scrubs or other clothing, and then properly take care of ourselves once we return home. Now we'll talk about screening questions. We want to ask the patient and make sure we include the family members and caregivers, whoever's with that patient, and visitors to the home about travel within the last 14 days. Now we know that COVID-19 is now in the community, so this question is not as important, but it is still listed as one of the triggers to identify risk. Right now I'm adding bullet number 2, and this has been some changes that happened the first week of May. We now have symptoms have been added to the symptoms to ask about, and also the time frame has changed. So now most current information in May of 2020 is signs or symptoms may appear 2 to 14 days after exposure to the virus. And the symptoms initially were fever, cough, and sore throat. Added signs and symptoms now is shortness of breath, difficulty breathing, chills, muscle pain, or new loss of taste or smell. So it's important to ask the patient about any of these signs and symptoms. And if they have these signs and symptoms, then that would be a positive screen, and then you'd want to do further investigation. In the last 14 days, have they had contact with others under investigation or known to have COVID-19 or are ill with respiratory illness? Residing in a community where community-based spread of COVID is occurring. And right now, number 4, the bullet number 4 is difficult to say where we do not have a community, unless you're living outside of a metropolitan area in a more rural location where you know there aren't cases. I would rather err on the side of assuming that COVID-19 is in my community. And then lastly, temperature monitoring. All of us should be taking our temperatures and making sure if we have fever or not, and that along with taking into consideration these signs and symptoms would help us to know if we have a positive screen. I have several references on the slide to further delineate more information as to what to look for and what to do about having a positive screen. Now, as a clinician, it's important that we're also asking ourselves these questions about those signs and symptoms. And now moving on to looking at emergency attention for COVID-19, this is newer information that was just released within the last couple of weeks. If someone is showing any signs of these signs, seek emergency medical care immediately. Trouble breathing, persistent pain or pressure in the chest, new confusion, and in our population working with home health clients, we have many patients that have dementia, that have mild cognitive impairment. It's very important to look at, is it new confusion? Is there a change in mental status? And if there is so, then that may be a reason to seek medical attention. And it may not be medical attention specifically for COVID. We know in our older adult population, the risk of getting a urinary tract infection is greater, and when they do occur, they occur oftentimes comorbid with altered mental status. So be aware of confusion. Inability to stay awake or to wake up, bluish lips or face, so you may see some cyanosis signs. These would be reasons to seek emergency medical care. And it doesn't mean automatically calling 911. You as professionals in the home need to triage out, is this something that the patient needs to be seen by their physician or their practitioner, NP or PA, in the office? That can be done that same day? Or are there vital signs and are there other things going on where, no, this is someone that I need to call 911 for and take it and get that taken care of? Regardless, for all of your patients, when you're working in the home at this point moving forward, you should let the operator know that you have someone that may have COVID-19 or not, because that may change what PPE and what availability they have. They may have ambulance corps that are COVID-19, and they may have to triage out who sees the patient differently. So I want to talk about self-monitoring a little bit more in detail. So we're going to talk about self-monitoring, self-quarantining, and then self-isolation. And I want to be clear about the definitions here. If you or someone that might have been exposed, then you want to be self-monitoring. So be alert for the symptoms, and I had previously just mentioned the additional symptoms. But watch in particular for fever, cough, or shortness of breath. Should be taking your temperature, should be practicing social distancing, and then follow CDC guidance if symptoms do develop. If you feel healthy but recently had close contact with someone with COVID-19, or recently traveled somewhere outside of the US, which is becoming less and less likely with all of the travel restrictions. But if that's the case, you should be self-quarantining. And self-quarantining is checking your temperature twice a day, watch for symptoms, stay home for 14 days and self-monitor, and then if possible, stay away from people who are at high risk for getting very sick from COVID-19. And that's a bullet that I really want to emphasize with our older adult population. Many of them are at a high risk. Because they have other medical conditions, their ability to fight this disease is less than others. So be aware of that when you're deciding on when to see patients. I just want to make a mention to recently traveling from outside of the United States. Even if you're traveling within the United States, it is a best practice if you've traveled, let's say you've traveled to New York, knowing that that's a hotbed of COVID-19. If you've traveled to and from New York, it is a best practice to self-quarantine for 14 days upon returning from that trip to make sure that you have not contracted this illness. If you have been diagnosed with COVID-19 or are awaiting results from a test or have symptoms such as cough, fever, or shortness of breath, then this is where we talk about self-isolation. Stay in a specific sick room or area in the home away from other people and animals now, including pets, if possible. We know that there's spread to some animals. Use a separate bathroom if possible. Read important information about caring for yourself, and this information is available on the CDC website. Now, most recently in the news, we've been hearing about contact tracing. So I want to just go over the definition of what this is and just elaborate a little bit on some information that we should know as treating clinicians with contact tracing. So contact tracing is when public health staff are working with someone who has been tested positive for having the disease of COVID-19, and then helping them to recall everyone with whom they've had contact with during the infectious time frame. So they will go back and say, you tested positive on Monday. Let's go back and see, where were you before Monday? Did you go out to the stores? Did you have visitors to the home? And then warn any of those people that were potentially exposed as rapidly and sensitively as possible, and encourage those people to get tested and follow up for what they may need to do depending on their risk of exposure. If that risk of exposure was very casual, let's say a momentary connection, and I don't mean physical connection, but just a momentary interaction, then the risk exposure is less. But if the person is with this person that is infected, and they're within 6 feet, and they're with that person for a duration of time, let's say with that person talking with the conversation for 20 minutes, maybe they ate a meal and they're at they were socially distanced, but they were having a meal together. The more exposure time with the person that is infected, the research shows that the risk of getting this infection is greater. So it's exposure time, not just a casual exposure, although there is a risk, it's just less. And then monitor for symptoms, illness symptoms, and then testing and care. But it's important to understand the 14 days because that's the length of time that it could show up for symptoms to first show. Now, a question that I've been asked a number of times is discontinuing isolation. So we put these things in place. When do we know we don't need to continue with them? So I added this slide here just to talk a little bit about what we know today in May of 2020 regarding discontinuing isolation. And so discontinuing isolation, we're going to be looking at it from a symptom-based strategy. So we're not looking at it based on a negative test. We're not looking at it from you were tested positive on one day and then now you're not testing positive. We're looking at it based on a symptom-based strategy. For persons recovered from COVID-19 illness, the CDC recommends that isolation be maintained for at least 10 days after illness onset and at least 3 days after recovery. So let's define what illness onset is and what recovery is. So illness onset is defined as the date symptoms begin. Recovery is defined as resolution of fever without the use of fever-reducing medications with progressive improvement or resolution of other symptoms. So it's very important to understand that people that are taking Tylenol or people that are taking other anti-inflammatory medications like NSAIDs, those may control temperature and not show the person has a fever. So this is defined as someone not taking those medications and having a normal temperature. Ideally, isolation should be maintained for the full period to the extent that is practicable under rapidly changing circumstances. So this is the best available evidence we have right now from the CDC for when to discontinue isolation. And as clinicians working with people in their home, we understand about sheltering in place. We understand about trying to minimize leaving our homes. But there are times where you may need to take your patient outdoors. This is information that will help give a little bit of guidance as to when it is safe to help to take that person that we had that has a known illness, when to take them outside. As far as clinicians working in the home, it's very important to educate our patients, not only on fall reduction techniques and not only on trying to help improve their safety and ADL function. It's very important at this point with the communicable disease to educate how to maintain a safe, clean home. So we need to go over how to clean and disinfect. We need to go over the use of soap and water and the use of hand sanitizers. Wiping high-touch surfaces, and there's a list that I have on the screen, and I'll mention it for those that are not able to see the slides. Tables, doorknobs, light switches, countertops, handles, anything that's a high-touch surface needs to be wiped, soap and water, and cleaned very frequently, including your cell phone, including your tablet, including your keyboard. Things that we touch, very high touch, need to be cleaned more often. Disinfect the areas in our home. Soap and water or another detergent if it is dirty. And then there's EPA household disinfectants. And then follow those labeling on those disinfectants. Some of those products need to be sprayed on the surface and then let sit there for a length of time and then get wiped and not immediately wiped. So follow the labeling instructions. Important to wash your hands. Soap and water is fine, it's 20 seconds. Hand sanitizer is fine, but follow the directions on the bottle. Avoid touching your eyes. Try not to have a shared bathroom if someone who is known to be sick. And then in the bathroom, we know we have high touch surfaces, the faucets, the lever for the toilet. So be aware of cleaning those surfaces quite often. And then food, we shouldn't eat food with people that are known to be ill. And we should not share food out of common bowls for people that are known to be ill. And then trash, have dedicated trash can liners and use gloves when removing the trash, and double bag that trash and discard that out into the outside pails. There's more information for disinfecting your home available on the link on the bottom of the slide at the CDC website. So I talked a moment ago about wiping surfaces and cleaning surfaces. The purpose of this slide, and this compares SARS-CoV-1 and SARS-CoV-2. So SARS-CoV-2, as you're seeing on the slide, that is the COVID-19 virus. And this study looked at the viability of the virus on various surfaces. So aerosols would be in the air, copper, cardboard, stainless steel, and plastic. And you can see that it lives longer. COVID-2 is very similar with its lifespan, viability with COVID-1, other than looking at cardboard. For cardboard, COVID-19 lives longer on cardboard, and it lives up to 40 hours. So typically we tell people 48 hours, 72 hours, 3 days. It also lives on plastic. It can live on stainless steel. So I'm not going into the depths of detail here, but just understand that all of our surfaces need to be wiped and all of our surfaces need to be clean. And traditionally in home health, we're told that we don't want to put our bags, home health bags, on couches, soft surfaces, and we still don't want to do that. But be aware that plastic surfaces, hard surfaces, with this illness, the virus is still there. So best practice would be to use a barrier between our bag and any surfaces that we're placing our bag on. We should always be using some form of a barrier at all times with our bag as a best practice. So I want to just talk about definitions for telehealth for just a moment, and then I'll pass it off to Melissa to continue with more clinical information. So the definition of synchronous telehealth is where a person, patient and the provider can see and hear each other in real time, allowing clinicians to perform a more comprehensive examination. We can ask questions. We could observe the patient doing specific activities. So more accurate history taking, more ability for observation. And then we can perform other exam components, as well as address interventions on the care plan through a medium where it's synchronous, where we can watch and listen and we can speak and answer questions with the patient in real time. That's what synchronous telehealth does for us. Asynchronous telehealth has been the model of practice in this country for a number of years. And asynchronous telehealth is where a person has a machine in their home that monitors their vital signs. It could be blood pressure, heart rate. It could be their pulse oxygen numbers. It could be their weight. Okay, so we have these different vital signs are measured. And then the patient may be asked a series of questions by a machine that's prompting them. Do you have any pain today? Do you feel shortness of breath today? A slew of yes or no questions. And based on those answers, that information, along with the vital sign information, will be transmitted to some remote station monitoring. And then on an asynchronous time or at a different time point, someone will review that data to see if there's any of the information that is falling outside of our normal range. So let's say blood pressure is 180 over 100, and the machine is set to trigger if it's 150 or 90 or higher. So since that number is higher than that alert number, that would then prompt a phone call back to the patient, which would be a telephonic call to ask the patient about medication use, to ask the patient about symptoms that the machine may not have been able to ask because it doesn't have that capability. So that's an asynchronous visit. I think both are useful, both are definitely helpful, but for the therapy discipline, being able to do an evaluation and to watch a person's movement, I think the synchronous visit has much more practicality and usability for us. But you will see both synchronous and asynchronous visits. And now, what are the benefits? I just want to mention the benefits of a virtual visit that's synchronous, as clinicians can verify that the patients and caregivers understand the information shared, that we were clear in our presenting that information, so we can use teachback with this method, and also make sure that the patient is able to follow that care plan. And then secondly, patients and caregivers have the opportunity to ask clarifying questions and verify that the information that they have received is accurate. So these are the main benefits of having a synchronous visit. Now, I want to just mention CMS has just recently changed the regulations. This is why regulations are important as well as clinical information. But they recently changed the regulations to allow telehealth visits to be done by home health agencies. They're not able to bill for these visits separately because it's a bundled payment arrangement. So you cannot bill for telehealth separately, but they are loosening up the rules to allow for telehealth visits to be made, so long as the telehealth is listed on the care plan. So we're following a care plan that has telehealth ordered. And secondly, the telehealth is not replacing in-person visits that are necessary for this patient's care. So if you create a care plan and you add telehealth, be sure that the number of physical visits the patient needs are what can be supported clinically and supported in the documentation that, yes, this patient needs one physical visit per week and one telehealth visit per week. So you would need to be clear in what you're writing on a 485, also known as the care plan. But be aware that this is an option that has recently expanded through CMS. Here are my references for you. And now I'm going to hand it over to Dr. Bednarek to continue with this discussion.
All right, thanks, Ken. Moving on to a little bit more of the clinical piece. So just sort of a really quick overview as far as the coronavirus disease 2019. So just from a terminology perspective, when we hear the term COVID-19, it actually stands for coronavirus disease 2019, as highlighted on this slide. And it's actually caused by the coronavirus. So the condition is the coronavirus disease 2019, COVID-19, caused by the coronavirus. In particular, as Ken mentioned earlier with some research, SARS-CoV-2. So there's a SARS-CoV-1 and a SARS-CoV-2. The one that we're currently battling as a society is SARS-CoV-2. So just a little bit about it is a positive stranded RNA virus with spike glycoproteins on the envelope that give it a crown-like appearance. So that's actually where the name coronum comes from, meaning crown is the meaning of coronum in Latin. So, and you can see here on the picture, I'm sure a picture we've seen across social media in the last couple months. Transmission we know is through respiratory droplets, through coughing, through sneezing. And this infection, though, is capable of generating in an individual an excessive immune response, sometimes referred to as a cytokine storm. So that's another term that we're starting to hear about. Another context in which we've heard about cytokine storm, it has to do with those individuals that have experienced this and the PICS, the post-intensive care unit syndrome. So that's sort of another context of which you might have heard about cytokine storm. In particular, it's interleukin-6, IL-6, which is produced by activated leukocytes in the infection process of COVID-19. And it's this IL-6 that's the connection with the multi-system effects. What sort of multi-system effects am I thinking about? So some of the signs and symptoms, we know that signs and symptoms typically develop 5 to 6 days after infection, but the range can be anywhere from 1 to 14 days, which makes one of the many challenges with COVID-19. As far as the signs and symptoms evident, fever in the vast majority, 87.9%, followed then by dry cough. About over 2/3 of individuals develop this, fatigue at 38%, sputum production at 33%, and other symptoms such as shortness of breath, myalgia, arthralgia, sore throat, headache, chills, nausea, vomiting, nasal congestion, diarrhea, hemoptysis, and conjunctival congestion. I should note that actually this was from a publication that I accessed in the end of March, early April. So as Ken already pointed out, the list of symptoms that we have now associated with COVID-19 has grown and continues to grow. So sort of from a percentage perspective, these numbers might be a little bit old, having accessed this, probably 6+ weeks ago. But out of this list of signs and symptoms, what I'm going to really sort of focus on is some of the pulmonary aspects. So we know too, though, as far as disease presentation, it's really there's a continuum. So, we know some individuals are asymptomatic, are not aware that they have the infection. Hence the masks, that Ken talked about earlier. So masks, again, are, out in public spaces are not going to prevent you from contracting the COVID-19 from another individual, but rather prevent the spread if you are an asymptomatic carrier of the disease from spreading it to others. So probably the vast majority of individuals have a mild to moderate disease presentation. This could include pneumonia or a non-pneumonia. Smaller percentage have more of a severe presentation that might include dyspnea, an elevated respiratory rate above 30, SpO2s less than 93%, and PaO2, FiO2 ratio of less than 300, and lung infiltrates on greater than 50% of the lung field in 24 to 48 hours. And an even smaller proportion, 6.1%. So again, also these percentage numbers are from April 2020. So as we learn more, as more time goes on, these numbers will shift. But just to sort of give some insight that even a smaller percentage have a critical disease presentation. So this could involve respiratory failure, septic shock, and multi-organ dysfunction or failure. So one thing that I want to sort of mention is this silent hypoxia. So the information sort of I gathered from this came from an opinion piece in the New York Times written on April 20th entitled "The Infection That's Silently Killing Coronavirus Patients" by Dr. Richard Levitan. So certainly, you know, in a session like this, we normally would not reference opinion pieces, but obviously, as we know, there's really, you know, research is starting to come out, but I mean, it's going to be a little while just because it's so new. So we're sort of looking for different sources of information where we can. So in this particular opinion piece, though, he really talked about this concept of silent hypoxia. And this is where individuals have been coming into hospital settings and when, you know, from a medical workup perspective, they have oxygen saturations as low as 50%. When we know, you know, healthy individuals should be, you know, 95 and above, for example. Even individuals with COPD, you know, typically acceptable would be, you know, anything as low as 88 to 90%. So these individuals are walking into hospitals with oxygen saturations as low as 50%. And that's sort of kind of the interesting piece of it, is that they're walking in, they're talking, you know, yes, you know, obviously ill enough to go to a hospital, but, you know, quite functional still. And, you know, this is just sort of mind-boggling that individuals are functioning with SATs at this low. What sort of the theory is that, you know, this obviously happened over a course of time, that the individual started to compensate for this with an increased respiratory rate and a tidal volume. So taking more frequent, deeper breaths. And that's sort of how they've compensated for this low saturation. However, over time, right, this is overworking the lungs. And eventually the individual can develop acute respiratory failure and potentially even require the need for a ventilator. So again, this is what's sort of interesting, is that, you know, individuals that are hypoxic like this are, you know, usually much more symptomatic. But what we're seeing with COVID pneumonia is that this is not actually the case. So some thoughts as far as, you know, being able to identify this sooner. So certainly trying to intervene before it gets to this point. One thought is through pulse oximeter monitoring, as well as positioning changes. So from a pulse oximeter monitoring perspective, so I do want to give credit to Morgan Johansson for the next few slides here from previous work that we did together that I'll mention towards the end of the session here. So with pulse ox monitoring, right, so patients may already have their own, or it may be part of the telehealth equipment that Ken mentioned as far as that patients might have available to them. So, you know, why do I mention this? As far as thinking about, you know, perhaps you have a pulse oximeter in your bag, but from a cleaning perspective, you know, we certainly want to be very vigilant with cleaning, and there's really no sort of general instructions for cleaning because different pulse oximeters require different, you know, different cleaning agents are safe or not safe. So you'd want to follow the manufacturer's instructions, but sort of keeping this in mind. So again, you know, this is a device placed on the fingertip. It could be a fingertip pulse oximeter. It could be a handheld pulse oximeter. And every pulse oximeter that you will ever come across actually will give you two numbers. One is the oxygen saturation, so the percentage in oxygen saturation, and the other is the heart rate. So I mention this because it helps to kind of verify. So what am I referring to? So perhaps, you know, any patient, COVID or not, you put a pulse oximeter on a patient and you're getting a reading of 82%. So certainly, you know, based on what I mentioned earlier, that's well outside the norms for patient populations that we're familiar with. So before you sort of act on that, is there any way you could verify that in the home? And the answer is yes. And that's because of the presence of the heart rate. So, you know, you see a pulse an oxygen saturation of 82%, you see that the heart rate is reading 44 beats per minute. So certainly we can always check a manual heart rate against the pulse oximeter, and assuming that indeed that is an error in the reading and that their pulse is not 44, we know that the device is not reading correctly. However, if the heart rate is within a couple beats of what the device is reading, then I do, take to be more true the value that I'm reading for the oxygen saturation. So just from a clinical perspective, just reminding you as far as how a pulse oximeter works, and that you have a fingertip between two LEDs and it's sort of picking up that pulsating blood. So, things such as poor circulation, if the digits are cold, dark colored nail polish, these are all going to limit the ability of the pulse oximeter to determine an accurate reading. The other thing is if you're thinking about verifying the pulse rate, so if you have, for example, the pulse oximeter on the left index finger, you would want to take the pulse on the other upper extremity, so on maybe a right radial pulse, thinking about the fact that if you actually took it on the left, at the same time you're looking at the pulse oximeter, that the process of taking a pulse, pressing an artery against a harder structure, is going to limit the blood flow to the pulse oximeter and thus the reading. So just recognizing that by taking a pulse on the same limb at the same time as the pulse oximeter, you're going to sort of skew your data. So just keeping in mind to take the pulse on the other extremity if possible. So just thinking about, a little bit of review again of pulse oximetry. As far as related to COVID-19, we don't really have any evidence yet that the dyspnea scales correlate with saturation or desaturation rates in COVID-19. So thinking about, the RPE scale, for example. So it's sort of something to keep in mind, but we don't have any good evidence yet. So as far as monitoring, so again, this could be in your, COVID-19 patient or your non-COVID-19, but we should be certainly monitoring at rest, keeping in mind the things I just mentioned as far as determining accuracy. During activities, so each time a new activity is introduced, as well as recovery. So again, that's what's nice about pulse oximeters is that oftentimes we can continue to monitor during the activity itself, depending on what it is. So that being said, so again, trying to avoid that situation of the silent hypoxia in individuals with COVID-19. Is there anything we can look for as far as nonverbal signs or sort of, not using a pulse oximeter as far as potential desaturation? The answer is yes. We can certainly monitor for increased respiratory rate, because I mentioned that sort of the compensation is an increased respiratory rate for those individuals that are developing that silent hypoxia. Complaints of shortness of breath or difficulty breathing. Assuming the rescue breathing positions. So sort of, that sort of comfort position, that tripod position with the forearms, for example, on the thighs and sitting. Over recruitment of the accessory respiratory muscles. So what am I thinking about here? I'm thinking about the sternocleidomastoid. I'm thinking about the scalenes. If you see prominent accessory muscles, they're, perhaps being over recruited. Perhaps the individual has found pursed lip breathing on their own as far as a way to help with their breathing and potential desaturation as well. And then also increasing anxiety. So again, nonverbal sort of signs and symptoms that we might be able to visualize with our patients. So that being said, strategies for managing desaturation. So certainly this could be in our COVID patients or non-COVID patients. Thinking about pacing. Right, pacing of activities, so sort of building in activities and building in rest breaks to those activities. So something even such as, like, for example, stair climbing. So perhaps, they have a flight of stairs, sort of educating them to stop every 3 to 4 stairs and just sort of pause, right? Rather than sort of running all the way up to the top and then being short of breath for the next 10, 15 minutes. Thinking about energy conservation through durable medical equipment. So for example, providing a 4-wheeled walker or even just a rolling walker to sort of decrease some of the energy necessary to maintain balance with upright mobility. And therefore conserve energy. Or even, in the bathroom, a shower or tub chair. So again, trying to decrease energy in the standing position for showering and that they're able to sit down. Thinking about selecting the appropriate intensity of exercise. So, just applying some what I just mentioned to exercise. So certainly standing exercises can be beneficial for strengthening, for endurance, for balance as well. But for somebody that is, if you have concerns about desaturation, thinking about maybe altering that. Maybe it's, coming up with seated alternatives. As well as breathing exercises. Certainly pursed lip breathing, diaphragmatic breathing, just to name a couple of different breathing strategies for managing desaturation. So again, I just want to mention this to sort of think about, monitoring in the home setting. So pulse oximetry, some other symptoms the patient might exist if they're desaturating, as well as some sort of immediate strategies you might be able to implement while they might be thinking about further testing and further follow-up with their healthcare provider regarding possible COVID-19 infection. So the second topic that I want to talk about is something we're hearing more and more about. So as far as proning, so we've heard a lot more about proning in the acute care setting. And so one question I've received is, is it helpful to continue to use this prone position in the home health setting? So my approach to this is just going to be to sort of present to you the evidence and sort of how it's been incorporated so far. And sort of, because there is nothing out there right now that says, using prone positioning post-acute is helpful or not helpful, or is harmful or not harmful. There's really nothing out there at this point. So where did this come from? Like, this idea of the prone position to help with pulmonary function is not new. And sort of one of the defining trials was in 2013, the PROSEVA trial. And this was proning in severe ARDS patients. So the population here was the acute respiratory distress syndrome. So as far as the protocol, they actually used early application of 16 or more hours at a time in the prone position for mechanically ventilated patients. So again, there was a very specific protocol. These individuals were already mechanically ventilated, and this was initiated early for periods of 16, I think the average was between 17 to 20 hours for that trial, that individuals were in the prone position. And they did find that it decreased 28-day and it still remained at 90-day mortality. So that's sort of some definitive evidence that we've had for a number of years now. Sort of getting into the actual specifics of what the prone position does to the pulmonary systems beyond the scope of this particular PACER session, but it certainly affects chest mechanics, the ventilation-perfusion relationship, alveolar ventilation, recruitment. And if you are interested in this, I would recommend and direct you to a webinar that was held on May 9th in conjunction between the Academy of Acute Care Physical Therapy, Cardiovascular and Pulmonary section, and the Academy of Clinical Electrophysiology and Wound Management. So it was a combined section Saturday webinar, if you're familiar with those. And they looked at overview of the prone position, why it works, and lessons learned. So if you're interested in more details, I would refer you to that particular webinar. So that was in the mechanically ventilated patients that where a lot of our evidence comes from. So then the Intensive Care Society actually just in the last month or so has come up with a decision tool for conscious proning. So again, this is for the individual who might not be sedated because of mechanical ventilation. So as far as their criteria, some initial criteria is an FiO2 of greater than 28%. So recognizing that the oxygen FiO2 of just room air is 21%, this could be as little as somebody needing 2 liters per minute of nasal cannula would be an FiO2 of about 28%, just to kind of put it into perspective. So it's not necessarily high oxygen requirements. Or that they require basic respiratory support to achieve an SaO2 of 92 to 96%. So I do want to mention that usually whenever as physical therapists we're using pulse oximetry, as far as documentation, it would be SpO2. Whenever you see SaO2, that typically refers to oxygen saturations as determined through direct, arterial blood sampling through an arterial line. So again, just sort of sharing the criteria from the Intensive Care Society. So if they're stating SaO2 92 to 96%, I suspect that was determined through, ABGs through an arterial line. So one criteria again was FiO2 greater than 28%, or they require basic respiratory support, and they have suspected or confirmed COVID-19. So the recommendations were to consider their prone position. If the individual is able to communicate and cooperate, to be able to move and adjust their position independently, and they're unaware of what the prone position and what the plan is basically, and you don't anticipate or there's no anticipated airway issues. So again, just to sort of, the first trial I just mentioned pertained to mechanically ventilated patients, and then here's a decision tool through the Intensive Care Society regarding the prone positioning and sort of initial criteria and considerations in the conscious patient. So just a little bit more about the protocol that they recommended. So some considerations. So as far as from the actual positioning perspective, They talked about, that pillows may be required to support the chest in the prone position, and that a reverse Trendelenburg position may be helpful. So again, just kind of a reminder, Trendelenburg is, the supine position with the feet elevated. So reverse Trendelenburg would be with the head elevated. So these individuals would be prone with their head higher than their feet for the reverse Trendelenburg. That once the individual changes position, you should monitor oxygen saturations for 15 minutes and looking for appropriate SaO2 and no distress. And that the recommendation is to change position every 30 minutes to 2 hours, okay, aiming to achieve a prone position for as long as possible. So sort of the sequence of positions that they recommend is going from the prone to right side lying to sitting up. And as far as sitting up, it should be between 30 to 60 degrees upright, to left side lying and back to prone. So sort of those sequential positions. And then again, monitoring, oxygen saturations for at least 15 minutes with any position change. So again, I bring all this up because thinking about what the evidence is. So the evidence really was from, the 2013 trial was with acute respiratory distress syndrome and mechanically ventilated. Certainly we have heard that it has been used with, different levels of success in the acute care setting with COVID-19 patients. And then there's been more discussion about conscious proning that I just described. So as I mentioned, there has been no research currently out there as far as using the prone position for patients post-acute. But I just want to sort of, mention the very specifics that they have talked about with conscious proning, and sort of, as the clinician, arm you with as much information as possible for you to make a decision whether this would be something appropriate for your patients in the home health setting. So there I have some references. And sort of one other additional note I wanted to make. As I sort of mentioned a couple minutes ago, a webinar last weekend, but there's been a series of webinars on Saturdays since the COVID-19 pandemic has really started, sort of in conjunction with multiple sections. So for example, the Academy of Acute Care Physical Therapy, the Cardiovascular and Pulmonary section, the Home Health section, and the HPA, the Catalyst. And there was one particular Saturday session on April 18th, Physical Therapy Considerations of COVID-19 in the Post-Acute Setting, that I had the pleasure of working with Ken Miller on, our other co-speaker today, as well as Pam Bartlow, Morgan Johansson, Talia Pollack, and we had clinicians Chris Chimente and Rachel Bodkin as well. So this is available through different, listed section websites. I believe it's also available through the APTA Learning Center. So again, free to everyone, although there is not CEUs available. So I just sort of want to mention that as a possible additional resource in that particular webinar. We do, actually Pam talked in more depth about some of the infection control procedures and specifically about the personal protective equipment. And Morgan actually also talked in more depth than I did just now regarding oxygen devices and monitoring as well. So just want to bring that out as a possible additional resource. So at this point, I'd like to thank you for joining Ken and I for the home health considerations as part of the PACER project. And again, a big thank you to the Academy of Geriatrics, the home health section, as well as the cardiovascular and pulmonary section for co-sponsoring this session. Thanks, stay safe and be well.